Hello, I think I'm on. Sorry, I just had a little bit of a flapjack before I started. Hello, and welcome back to the Critical Care Practitioner Facebook live stream. I hope you can hear me. If you can't, then you're going to have to lip read. You can hear me. I'm sure you can hear me. Hang on. Yes, it looks like you can hear me. Brilliant. I always forget to turn the microphone on, so let's just adjust that very slightly as well. Yep, all good. Right, so we're going to talk about cardiac output today. Now, I know, sorry, that's annoying me now. Now, I know that a lot of you will have come across the term cardiac output, and those of you that work in intensive care will be familiar with some of the machinery that we use to measure cardiac output state of our patients. So things like the LIDCO is what we use in our department. So really, I just want to help you understand what cardiac output is. Now, I apologise first thing here. I can't find my pen for my little drawing tablet. So normally I would do a kind of chalk and talk and write on the screen. I'm going to try it, but I've had to reduce myself to death by PowerPoint. Now, don't worry, there's not lots of bullets. I'm not going to be droning on for hours, and there's not lots of stuff to read. So without further ado, let's crack on. Otherwise, I risk boring you all to death. So the first thing you need to know is cardiac output. So cardiac output is stroke volume times the heart rate. So essentially, cardiac output is how much blood the heart ejects every time it beats. And this is per minute. So heart rate, we understand how fast the heart is pumping. So let's say our heart rate is 70 beats per minute. And let's have a go at drawing on here. Please forgive me if my drawing is a little bit iffy, but let's have a go. Hang on, let me get the pen. So let's say our heart rate is 70 beats per minute. Okay? Standard heart rate for a healthy adult. I know a lot of our patients are going to be tachycardic, but it makes my maths easier as well. And the normal stroke volume. So what is stroke volume? So stroke volume is the amount of blood that is ejected from the heart, from the left ventricle, every time it contracts. So during systole. And a normal stroke volume is approximately 70 mils. Approximately. It's going to vary depending on the size of the person, etc. So that would give us 70 mils times 70 beats. So it's going to give us 490 mils or 4.9 litres, or let's just for argument's sake call it 5 litres. Yeah, sorry. 5 litres. I'm having to do this with a mouse, and normally I have a pen. So cardiac output 5 litres per minute. Okay, so that's it. That could be it, but there's a bit more to it than that. Now the heart rate is going to vary depending on the patient's physiology. So obviously a lot of our patients in shock, for example, are going to come to us. They're going to be tachycardic. The body has responded to the low volume state and has increased the heart rate. And the reason it has increased the heart rate is because it's trying to compensate for the low volume of low volume in the circulation, so it's trying to compensate by increasing the heart rate to increase the cardiac output because of the low stroke volume. We can increase the heart rate if we need to. It's not something we do very often, but we can increase it with drugs like atropine or glycopyrrolate. We can slow the heart rate down if we want to. We can use beta blockers, for example, metoprolol, betalol, all the olols will slow the heart rate down. Digoxin will do that to a degree as well. So we can affect it. But the thing that we are going to be affecting most when it comes to the cardiac output is probably the stroke volume. And this is where we come to three really important terms when we talk about cardiac output. So we're going to be talking about preload, contractility, and afterload. So these are the three key things that will affect the stroke volume, the amount of blood that is being ejected from the heart. So what is preload? So preload refers to how stretched that cardiac muscle is. I am on double screen, aren't I? Yes. How stretched that cardiac muscle is before it actually ejects. So think of the heart as a big balloon. So hold on a second. So think of this muscle around here as like a big balloon, like a big fresh balloon. It's a new balloon. It's got good stretch to it. And we, before it ejects, are filling it with fluid. So let's have a change of colour. Here we go. Let's go for that nice bright colour. So fluid is coming in through here. It's coming in via the vena cava here. So you've got the IVC and the SVC. Blood's returning from the body, coming in through the right atria, into the right ventricle. And then on this side, obviously, it's returning from the lungs, coming in via the pulmonary veins. So your pulmonary vein here, you've got the left atria and the left ventricle, and then up here we have the lungs, and the blood is returned from there. So if we only have a very little amount of blood returning into the atria before contractility takes place, sorry, I'm trying to draw it, it's not very easy, then the heart muscle isn't going to be stretched that much. So imagine again that this is your balloon, and the I'm filling it with fluid, filling it with only a small amount of fluid. As that balloon then contracts, because there isn't much fluid into it, you're not going to get much out of it. If I then filled that balloon, let's say I filled it up to here, and that balloon then contracts, then I've increased its preload. I've got more fluid in there. There is more fluid now to eject from that ventricle. So then when it contracts, let's assume it contracts the same way it did before when it was not so well filled, you're going to get more fluid coming out of it. So that's preload. How stretched are the ventricles before they actually contract, and the stretchability of them is affected by the amount of fluid that we actually put in. Let's get rid of all this now. So that's preload. So how can we affect preload? Well, very simply, hang on. Oh no, my mouse has died. Oh, nightmare. You're going to have to bear with me while I get a new battery for my mouse. Hold on 1 second. The disadvantages of live television. Hold on. My mouse has died. Back. Right, let's hope this battery works. Hold on a second. Yes, right, okay, so let's get rid of that. So it's affected by how much fluid we give our patient. So if our patient is particularly dry, the preload is going to be quite low. So at the amount of fluid it ejects is therefore going to be quite low. One of the things that we can do is we can give the patient fluid. So if we give them more fluid, hopefully we're going to be increasing their preload. Now obviously patients who are septic, for example, you need to be quite careful with this, because the problem is the kind of fluids that we tend to give our patients, and normal saline and crystalloids generally being the worst culprits here, is that the fluid doesn't stay in the circulation for very long when you give it. So if you give, let's say 500 mils of normal saline, after about 20 minutes, most of that is not now in the circulation anymore. It's in the tissues. This is why I write to you patients, we give them loads of fluid, and 2 or 3 days later they look very, very edematous and swollen, because all that fluid we've given them is in the wrong places. It's not in the circulation anymore. So probably the ideal fluids to give them, if you needed to and if it warranted it, would be something like blood, but obviously a lot of our patients don't need that, so we give them crystalloids as a consequence. Albumin, there's a whole debate out there about whether one should give albumin or not. Does it stay in the circulation any longer? Does it break the kidneys if you give it? Lots of debate, lots of research. I have seen more albumin being given recently than we used to, but again, the jury is out on that. So that's preload. So how can we affect preload? Give the patient some fluid. Be very careful, because the next part is contractility that I'm going to talk about. Now imagine that you've got your balloon again. So this is a nice new balloon, healthy balloon. You stretch it, it contracts beautifully. You stretch it, contracts beautifully. But if it's an old balloon, that old withered balloon that was in the corner of your room and has sat there for ages after the party 3 weeks ago, it's got that horrible crinkly appearance to it, hasn't it? So if you then fill that with fluid, it just doesn't contract as well, because in our case it's an older heart. Perhaps the heart's been damaged by somebody having a myocardial infarction. Perhaps they've got some element of left or right ventricular failure, so the muscle is just not contracting as well as you would like it to be. They could have a degree of cardiomyopathy or cardiomegaly. With a myopathy, you've got an overgrown muscle almost, which kind of is filling the ventricle almost, not allowing the ventricle to fill as well, and also not contract as well as it could. So if your contractility is poor, then your cardiac output potentially is also going to be poor. So this is where we have this heart muscle around here, up there and around here, is now being affected, in that it's not contracting well. And what can we do about that? Well, we can give drugs to aid that contraction. So certainly from an intensive care point of view, we give drugs like adrenaline, which will act on the receptors in the heart and increase that contractility a little bit. Patients are given digoxin for that very reason, because it just helps improve the contractility very slightly in the heart. The problem for us in intensive care is if we give patients adrenaline, what it might also do is it's going to stress that heart. You're forcing it to contract a little more than it necessarily wants to, and that's when the patient starts to overproduce things like lactate. And you'll see that when you do your gases and you put them on adrenaline, the lactate starts to rise, and it's kind of a balancing act between the patient's cardiac output and the fact that the lactate is starting to climb. There's an element of anaerobic metabolism going on, which is not doing the patient any good at all. So we have to be a little bit careful, certainly in intensive care, about giving them things like adrenaline. If we know the patient, it's purely if it's not a septic picture, and we'll talk about sepsis in a moment when we come to afterload. If it's not a septic picture, and we know the patient is purely a cardiac problem, so they've perhaps come in with an element of failure, perhaps come in having had an MI, then adrenaline by itself might be the ideal drug. Dobutamine is the other one that's often given. The advantage of dobutamine is that it centrally vasodilates, which means that there's less blood returning to the heart, and I'll show you this. So the problem that these patients have is that if there is loads of blood returning to the heart on this side, and their ventricle isn't contracting very well, it gets a little bit overwhelmed, and the fluid backs up and backs up and backs up, and then causes problems like pulmonary hypertension, cor pulmonale, those kinds of things, which is going to make the patient's breathing very much harder. If you vasodilate their vessels here and make them much wider, it means that you've dropped the resistance in those vessels, and as a consequence, not so much blood. Let me just rub these out. Not so much blood will then, you'll get less blood returning to the heart, and as a consequence you're not overwhelming that heart with that fluid. So that's the point of the central vasodilation. But the dobutamine also increases the contractility very slightly. So the reason we don't like giving dobutamine in intensive care is, again, commonly because our patients are septic. So the last thing we want to do is vasodilate them, because they're already vasodilated because of the sepsis. And if we vasodilate them more, it's going to make the problem even worse. So dobutamine and adrenaline is something you tend to see used in places like coronary care units. So let's get rid of those. And then the final part of cardiac output to consider, and again something that we can affect, is something called the afterload. So the afterload essentially is what pressure is the heart pumping against when the blood is ejected from the left ventricle into the circulation. So it's going to go through the aorta and into the circulation. Now, if the circulation is quite tight, so if the vessels are quite tight that the heart is pumping against, that's going to increase the blood pressure. You've got a higher resistance that the heart is pumping against. It's going to increase that blood pressure. However, if the circulation is very open, very vasodilated, septic patients, the immune response causes massive vasodilation. It now means that the heart is now pumping against a very unresistant circulation, and the blood pressure as a consequence will fall. So what do we do in intensive care? Is one of the main drugs we give is noradrenaline. So noradrenaline causes vasoconstriction, which means that, as I said, the heart is now pumping against a tighter circulation, which will increase the patient's blood pressure. And really that brings me to the last slide of this very quick session, that your blood pressure basically equals cardiac output times SVRI, so systemic vascular resistance. Ignore the I. The I just relates to the actual cardiac output studies. I relates to that particular patient's height. It's an indexed one. It's a bit like cardiac output, cardiac index, SVRI and SVRI. So they're the numbers that you're looking at when you're talking about cardiac output. The other value you may see on things like the LiDCO machine is the stroke volume variation. So that basically is telling you when the patient breathes in, the pressure within the circulation will change, because as they breathe in, the whole thoracic cavity's pressure will change, which means that you'll get a very slight swing in the stroke volume because of that pressure change. It's a bit more complicated than that, but that's what's going to happen. You'll get this variation. Now, if they're very well filled with fluid, that variation will be quite minimal. But if they're very dry, that variation will be quite severe. So what you're looking at, the stroke volume variation, and I'm kind of quoting LiDCO a little bit here, it's the machine I'm familiar with, is that you want it no greater than 10%. You want that variation to be no greater than 10%. If it's more than 10%, and you think the patient is on enough noradrenaline, because your SVRI is sitting at about 2000, which is a good number for an SVRI, then give them more fluid. If you give them more fluid, let's say you give them 250 mils, let's say your stroke volume variation is 15%, you give them more fluid, it drops to 10%, hopefully you'll see an improvement in their blood pressure as well. Then you have improved their stroke volume by giving them some fluid, and you can relax. Give them a bit more if it doesn't change dramatically. But again, be very careful. Make sure that you're actually looking at the patient as well, not just at your LiDCO machine. You know, how do they feel in the peripheries? Are they very cool at the peripheries, which means they might be very tight, they might be very shut down. Perhaps we're overdoing the noradrenaline a bit. Or are their peripheries nice and warm? In which case it means we are perfusing those peripheries. We've got the noradrenaline right, but they might still be a little bit dry. So that's cardiac output. Just remember, going back to the first formula, cardiac output, stroke volume times heart rate, and then the stroke volume is composed of your preload how much fluid you put in, your contractility, how well does your heart pump, an older heart might not pump so well, and the afterload, how tight is that circulation that the heart is actually pumping against. Preload is fluid, contractility is some of those drugs that I mentioned, adrenaline and dobutamine. To a degree, noradrenaline does increase contractility as well, but not as well as adrenaline or dobutamine. And then afterload, that for us is mainly noradrenaline, trying to offset the effects of the sepsis that the patient's experiencing. I hope that's helpful. Please keep telling me what you want me to teach you. If I can, I will. These are very quick sessions, really just to help you along and to get it in my own mind as well. And I hope you could hear me. Okay, see you soon. Bye bye.